Hello, and welcome to the webinar, Ask Nurse Linda webinar for today. It's the last Wednesday of the month, and we're here together. And I'm so happy everybody is here today, or if you're listening at a later time, it's just wonderful to be with you. I meet a lot of people, and it's wonderful when I meet you guys out in real life. And I know we have a lot of people from the community that attend, a lot of family members. But I also want to give a shout out to the people who are in school learning about paralysis because there's a lot of schools that play the Nurse Linda webinar. So, hello to you. We have some rehabilitation facilities that will use the Linda webinars as their in service time. So, hello to all of you. And sometimes we have people from insurance companies and people who are selling products, particularly for people with paralysis who listen in. So I appreciate everybody's support and listening throughout all these years. We've been doing this for quite a long time. I'll describe myself. I am a lightly pigmented woman with brown hair. I have clear colored glasses on today. And I have a white shirt on with a blue sweater over it because it's a little chilly today. And I have the Reeve background, which is navy blue with orange, yellow, and red uh, design on it. So I am very happy to be with you today. And we have a lot of questions, so we're just going to dive right in. And it's been interesting through the years. There gets to be kind of themes that come up. There's always some questions about certain things that come up all the time, but there's some things that seem to be bothering the, people are from all over the country, people from other countries listen, and there's always some themes that kind of pop up. And right now we're in a bowel theme. So heard me talk a lot about bowels. It usually pops up almost every webinar, and that's fine because we all need to figure out what's going on with this, and the bowels can really give us a lot of trouble. So I've gone through and I'm going to try to answer all the bowel questions in a row, and then we'll get back to the other questions because I think that'll kind of help pull it together. But we have a person who's a C4 C5 quad for 40 years. Okay, so for 40 years the bowel program has been going just great. Now this will sound familiar to a lot of you. Bowel program goes just fine until one day it doesn't. And so he's been doing it 3 times a week and everything was going well, except for the last 2 years. And he started having some problems. And he's now doing 4 or 5 programs. And then the question's cut off. So I'm not quite sure. But anyway, you're having problems now. And this happens. 40 years is a long time to be successful. So, number one, congratulations on that. But when problem arises, it's very irritating to have problems with whatever's going on. So, it's probably a consequence of aging because if you have paralysis or if you don't, our bodies, especially our bowels, tend to slow down as we age. It's just a natural part of the aging process. And so he's having some problems with his bowels. So I'm not exactly sure what you're doing with your bowel program, but there's some strategies. Make sure you're drinking enough water. And at C45, I would guess you're probably not intermittent catheterizing, but you could be. So sometimes intermittent cath programs restrict the amount of fluid, which makes it a little bit more of a challenge um, for drinking as much water as you need to keep that bowel functioning. Remember, as long as you said you were doing it 3 times a week and that was working out fine for you, so that's great. Mostly we recommend an every other day bowel program. And if you can get away with 3 times a week, a lot of times people who tend to do it less than every other day have more problems. Now, this was not the case for this particular person, but you might want to look at doing it every other day, review the roughage, because what we put into our body is what's going to come out of our body. And the reason why I stress this so much is because the whole time that stool's in your bowel, water's being taken out. Sometimes the stool's not being propelled along in the bowel, either through peristalsis with the bowel squeezing. It squeezes as it pushes the stool along. There are some little fibers, cilia, they're called. They look like little tiny hairs along in the inside of the bowel, and they kind of help propel the stool down. But the whole time the stool's in the bowel, water's being extracted from the stool because that's what makes it solid enough to be able to push out of the body. So it goes in the top, and as we digest, it becomes liquid. It's called chyme. Saliva breaks down the food. Your stomach has a lot of acid in it, breaks down the food, and then your small intestine's breaking down. So it really goes through there, and as it goes through the larger intestine, it tends to solidify. So that, it's kind of miraculous the way it works out. But the water is always being extracted. So as you get older and as you have spinal cord injury, the bowel slows down but the water's still coming out at the same rate. So that can be a problem. So some things you might want to do if you're having trouble with consistent stools, I would assume that you're using a suppository. You might want to try one of the mini enemas. Now, um, it's like a teaspoon or a tablespoon. It's a little tiny bit of fluid that's just injected into the rectum, stimulates the bowel to move. That can be helpful. Some people will add Miralax to their routine, which is um, it's called a laxative. Laxative covers a lot of territory. It's not a laxative like a that's going to cause your bowel to work because cathartics will take over working your bowel so it stops working on its own and then you end up with more. We never recommend like laxative medications, cathartic laxative medications, full enemas, but these little mini enemas are so small. They work kind of like a suppository. Now, the suppository and the enema, the mini enema, has to be placed up against the bowel wall. So you might have to remove some stool to get to the bowel wall. You might have to, um, do some other kinds of things. You might have to like crook your finger to get that suppository to push up against the bowel wall because that's where the suppository has to be against or the mini enema fluid has to be up against the bowel wall to stimulate. Then it works up the bowel and starts shaking things up there. So that's good. Miralax is something that people take because it adds water to the stool. So it helps put more water in the stool. So that's very helpful. We used to tell everyone, I emphasize used to tell everyone to take Metamucil. We've stopped that. That's not in the clinical practice guidelines anymore. Now, some of you might be taking Metamucil. It works for you. Don't disrupt what works. Keep going with it because you're taking it correctly. The problem with the Metamucil is so many people were unable to or were maybe taught to take it incorrectly. If you read on the package, it'll say you need 8 ounces of water. Well, if you're on a bladder management program, you can't drink that much water. I see places where people will take a 30 cc medicine cup, which is a lot less than 8 ounces, put some Metamucil in there and stir it up, and here's your Metamucil. Well, when you don't take enough water with the Metamucil, it causes a rock to form. That Metamucil becomes hard like a rock in your bowel and stopping your bowel. Okay, now get your roughage. People can get enough roughage from their diet, and so we say to do that. So that is just in fact the case. So there's a question there. Why would a C4-5 not need to intermittent catheterize? That's not exactly point that I was trying to make. Usually, at the C4-5 level, um, people now have a sphincterotomy, where they cut these internal sphincters so that the urine just flows out because people at the C4-5 level have a lot of autonomic dysreflexia. The number one source of autonomic dysreflexia comes from a problem in the bladder. So if the sphincters aren't working correctly and the sphincter's tightening and the bladder's pushing and the urine can't come out or the catheters kinks or there's all kinds of trouble that can come with urine, expelling urine. So, gentlemen who have that high level usually have a sphincterotomy, and they wear an external catheter. Now, you have to be doing something for your management at that level. C4-5, they might not have enough hand function to be able to catheterize them, so they would need an attendant to catheterize, hence the doing the surgery. You have to do something. If you have enough hand function to do intermittent catheterization, that's great. You're golden. So that's something very positive. So those are some things to kind of help get that BOW program going. Out of all those things, the number one thing that will help a BOW program that people give up right away after they get home is to do their stretches. Sometimes it's called range of motion, but do some kind of exercise to your lower body. And it doesn't matter if you're quadriplegic, paraplegic, if you have a spinal cord injury, if from like one of the spinal cord syndrome, or if you have neurogenic bowel and bladder from a head injury or stroke. 60% of individuals with head injury or stroke have a neurogenic bowel and bladder. Or if you have it from neurological disease, it doesn't matter. You need to consider that your problem is a neurogenic uh, bowel or bladder. They usually come in tandem because the nerves come out of S4-5 and go to both. So it usually comes in tandem together. That's a problem with nerve function. So that's very important to remember. You want to treat what the problem is. And so obviously, if you have that level of injury, you might not have that much motion in your legs and getting your legs moving. So if you can't move your legs or if you can't exercise them on your own, have someone move them for you a couple of times a day and get back to doing those stretches. Become involved if somebody else is doing while they're moving your leg, watch them moving your leg and think, oh, they're moving my toes. Now they're moving my ankle. Now they're moving my knee. So that you're thinking that, sending a message down while that movement is sending a message up so that hopefully you can make a connection. But getting that movement in, a lot of people who have constipation as a problem, that's different from neurogenic bowel. So a lot of people have constipation whether they have paralysis or not. That's in addition to. And so what happens is, we recommend you drink more fluid and you more movement in your body to help that stool get through there. So those are very important things to be. Now we have a person that their digestive system has gotten so bad after their SCI because, as I explained, it's because of that slowing of the bowel. They have a bowel movement regularly, but they get bloated after they eat. It's super painful, nerve pain, spasticity, discomfort, and they've tried everything: diets, neuropaths, and supplements and antibiotics. So they're having a problem because of all this bloating. Well, now bloating is gas in the bowel, and it's one of the things that's helping move the stool along. So we get a lot of complaints about bloating because when you have paralysis, a lot of times if your abdominal muscles are affected, they become lax. So they're not tightening as they should, and so the bowel's able to expand out because the muscles aren't holding the bowel in as tightly as it would be if you had muscle control. So this is one of the issues. If you're taking antibiotics, that's wiping out the flora, which there's good bacteria in your bowel, which is helping this digestion and breaking down the stool so you can get the nutrients out of the stool. And so there's good bacteria in there, and you want that bacteria to be there. A lot of times people take an antibiotic and they end up with diarrhea after it. That's flushing out all that good bacteria. So antibiotics and stools aren't friendly. Now, if you have an infection and you need to take it, you need to, and if you have diarrhea, you want to talk about maybe taking something to restore that flora in your bowel to help you with your bowel program. So antibiotics are friendly to the bowel, but it's one of those things we have to do when we have an infection because infection is more risky than taking the antibiotics, especially when you have paralysis. Supplements, again, those might be, I don't know what this person took, but there might be some kind of fiber supplements or something that they're taking to kind of help push that along. There's a lot of people, again, who confuse constipation with neurogenic bowel. If you have a neurogenic bowel, that's a nerve problem. And so a lot of the treatments for constipation are not going to work for you. But people think, oh, I'll just take more and more. It's the bowel program that has to be accomplished to eliminate the stool. For right now, there's a lot coming out on the horizon. And I know people hear this all the time and they think, oh, yeah, it's just around. Oh, it's going to be. But there's stuff that's literally getting FDA approval. There's things, with the transdermal stimulation, and there's all kinds of things that are actively coming out right now. So, sometimes people think, oh, I'm going to have to do this bowel program for the rest of my life. And that was true up until maybe a year ago. But, now we know we have things that are going to help. Now, are they really accessible to you right now? Well, some of them are, but some of them are not because, it takes a while to get things marketed and, teach people how to do all this different, stuff and all these different treatment plans and everything. But it's in process. It is in process now. So that's at least a good thing. Um, I don't know what the naturopaths were doing. My guess is they were probably treating constipation because that's not going to really treat neurogenic bowel. Diets, thinking about it, that, if you can add more roughage to your diet, you can go online and Google, or we have a bowel program booklet, and it will have all kinds of foods that have roughage. And you look at the list and you think, oh, I don't like that. Oh, I don't like that. But there will be several things on the list that you do like. Now, if you want to know what your transit time, that's the time how your bowel is working. You want to know. You can go to your doctor and get a transit time test, and you might want to do that. Or you can eat some corn at one meal. Note when you ate it. I had corn for noon at lunch. Okay, mark it on day. So mark it down on a piece of paper. And then don't eat any more corn until you look at results of your bowel program because they're custom. You see corn in stool, back in paper, process that corn. That's your transit time. And so it's kind of a cool little thing. It's not harmful to you unless for some reason you can't eat corn. You don't have to eat an abundant amount. I mean, 3 or 4 bites is more than enough because the corn's going to come out the other end. So it's kind of something that's nice to see, but again, movement is what is probably going to be your most helpful thing in your diet is movement. So again, that's another bowel thing, and I'm going to be saying that on all these bowel things because it's so very important. And then our next one is for bowel management is sienna, a laxative. Technically, it is classified as a laxative, but again, it's one of these laxative that's not a cathartic laxative. And so a lot of people use senna. Yeah. A lot of people use different kinds of little tiny nuts or spices. You only need a little bit. They can be a little bit unreliable because, again, you don't know how long it's going to take. Sometimes if you take a little bit of senna today and tomorrow and the next day, at some point it builds up in your body and then you're having incontinence. So it's kind of a little bit hard to regulate. Laxative, again, Miralax, most healthcare professionals will say that that's okay. Always check with your own healthcare professional because just because everybody else is doing it does not mean it's the right thing for you. So always check. And a bulking agent again is the Metamucil, and we're saying, yeah, we're not going to do that anymore. What's the difference between the suppositories, the Ducalox, or the Magic Bullet? It's the coating. The coating is the difference. Dugalox has a coating, which some people like because they'll put the suppository in, and then by the time they get to the toilet, it takes a few minutes for the coating to melt. If it's up against the bow wall, if you put it right up in the middle of a stool and it's not against the bow wall, there's not enough body heat inside the stool to melt the coating. So it doesn't work. It just comes right back out. That's a problem. The magic bullet does not have the coating, so it takes less time for it to. So some people, they're Dugalox all the way. Some people are magic bullet all the way. It's a matter of personal preference. The actual substance within the suppository is the same. It's the coating. That's the difference. Now that what I was talking about, that mini enema, that is a liquid, so that's even quicker to work if it's up against the bow wall. If any of these are not up against the bow wall, they're not going to work. So, some people have their way. They want a little more time. Some people want to put the suppository in when they're on the toilet. Some people put the suppository in when they're on the toilet and it falls out because they don't have the sphincter control to hold it in. So then they want to do it in bed. Then the magic bullet works better. So you see, you just have to decide, what's your thing? What's your thing going to be? And then they have some questions about some medications, and I'm not going to list off their names. Well, maybe I'll say them because, it's just easier but then everybody knows what we're talking about. But what they're looking at are medications for people who have irritable bowel syndrome. That is different from a neurogenic bowel. So if you're taking a medication for irritable bowel syndrome, it's not going to work on your neurogenic bowel. Just like if you take something for constipation, it's not going to work on your neurogenic bowel. The sad part of this story is you can have a neurogenic bowel, you can still become constipated, you can still get irritable bowel syndrome. I think that is so unfair, but just because you have paralysis does not mean you're immune to other diseases or issues that happen within the body. Seems unfair. So, so some of these are, well, motegrity is one that it they have that word because they want it helps with motility, but it probably is not going to help with neurogenic bowel. Sometimes used for irritable bowel. Linzess and Amitesia are both specifically designed for irritable bowel. Now, I think Linzess at one time they were saying they recommended it for spinal cord injury on their webpage, but I looked on their webpage today and I didn't see that. So I'm not sure if that's still there or not. When Linzess first came out, it was heavily advertised on TV, and everybody with paralysis wanted it. And so I called the Linzess people, and at that time, they were not recommending it because they hadn't done any testing with it. So I don't know of testing that's been done with Linzess, which doesn't mean it's not been done. And neurogenic bowel, I just am not familiar with it. But I know a lot of people, when it first came out, they took it, and the majority of people, it didn't really help their bowel at all, so they went off of it. And anesthesia is for women in particular with irritable bowel. And then the question is every third day okay to do your bowel program? And again, for some people it is, but remember that stool's sitting in there drying out, drying out, drying out. So some people will do the bowel program. Most people will do it every other day. To get on every third day is a rare bird because there's always more problems with that because you're drying the stool out too long. But check with your healthcare professional if your stool is moist after the third day, but again, when you have that dry stool coming out, you can get fissures and hemorrhoids, diverticulitis. There's can be all kinds of complications that we do not want. So, think about those kind of things. Thought on hot pads. We don't ever really recommend hot pads because if you don't have sensation, it's going to burn you because you might not feel it. Acupuncture. Some people abide by alternative medications. Now, if you go in with the attitude that this is not going to work, I'll try it, but it's not going to work. It's not going to work because there's a lot of your mindset that has to deal with any treatment. If you get a medication from your physician and you think this is not going to work, you might have trouble with that medication, So you have to go in with an open mind with the acupuncture. Now, do you want to go for an acupuncture every single time you're doing your bowel program? Well, that could get to be a bit much. But will it help the motility of your bowel? Maybe, so that might be something. It's not for everybody. I think that people are always looking for what is the magic fix. And we all human are basically the same. But just look at us. We have different color eyes, different color hairs. What we see on the outside is different. No two humans look alike unless you're identical twins, and that's a different situation. But no two humans are really alike. And even in identical twins, there are differences. Those same differences extend inside the body. So sometimes people will go in for an appendectomy, and the surgeon knows where to do the surgery, but the appendix is in a little bit of a different place, located a little higher, a little lower than the average, because we're all different. So you have to experiment and find the bowel program that's really going to work for you. Also, gravity is our friend. If you do your bowel program sitting up, gravity is going to bring the stool down and out of your body. Now, you're still going to have to do your digs, you're going to have to do all that, but gravity is going to help that come. So learn how to do your bowel program sitting up. When you're doing it in the bed, you're trying to push your stool out sideways. You're not taking advantage of our friend gravity. It's our friend in bowel programs and bladder programs. Gravity is our friend. Now, the FES, I wanted to spend just a minute talking about this because, as I was saying, this transdermal um, tape's a little more than functional electrical stimulation, but it's a tape. It's got electrodes. This has been approved by the FDA. The Onward company has approving it, and they're putting it out in market right now. And they're putting it out by areas because it's a lot to do, again, to educate people and how to do this and what to do. You've got to have your therapist, you got to have your doctors and nurses involved. So, it's a lot. It's a lot to, you can't, this is not the thing that you can just put it, here it is. But basically, it's a strip of tape. You can put it up right over your skin, up higher, and it can maybe help you with hand function. You can put it lower over the small of your back where that S4 and 5 comes out, and it can help with your bowel, bladder, and sexual function in men. We don't know about sexual function in women because people don't know how to assess that. Men, we can visually see when a man is having an erection. Women, we can't visually see what's going on, so it's a lot harder to assess that. But anyway, this is out in the market right now. So I am optimistic, but I am always optimistic. But I am optimistic that the way the tide is turning, that people are going to be getting these devices, and I think that that you're maybe not going to have to do a bowel program, or maybe it won't take as long. Maybe you still have to do your bowel program, but it won't take as long. It's not a magic cure. It by far is not a magic cure. It's going to work for a majority of people. It might not work for some people, because everybody is different. So we have to see. So I'm very optimistic about the future. So now we're going to step away from the bowels for a moment and talk about somebody is wanting to know how can we alert the ERs across the nation about caring for paralyzed people who need to relieve themselves when they're being forced to wait sometimes over 24 hours in the ER. I think if you've been to the ER, the hospital, you've experienced this where people really don't know how to care for things, that the specific needs of people with paralysis. So bring your Reeve information with you. Bring your bowel program book. Bring your skincare book. Bring your, the little booklets. They're all free. Nothing is ever charged for. So bring all of that with you. Your skincare, your bowel, and your bladder treatment. If you bring too much, it's going to be overwhelming. But if you bring enough, and hopefully you'll have people. Obviously, this person did not run across somebody who was very helpful in their unique situation. And you'll find that a lot in the ER because people maybe or work in the ER, they may go their whole career and never see somebody with paralysis. Hard to believe, but it happens. So we have a wonderful advocacy program. So this person has a fire in their belly. So contact our advocacy program because you need to get with them because you could start a movement in helping everybody. And so that's what we want to see. And our advocacy program is just fabulous. Okay, there's a message here on the question and answer that June 2 is a Medicare meeting that the public will address the coverage of the Parastine for bowel. And there's a link there in the question and answer box if you are interested in doing that. So, Dawn, thank you for your advocacy. You might want to contact our advocacy program so that make sure that they are aware they are aware of everything that's going on in the government. But you could get involved with them, and that would be a good thing. Here's a person who has MS and they have a C3 lesion for 24 years. They have a new issue called Raynaud syndrome and low blood pressure and bradycardia. I'm wondering about circulatory and cardiac risk. And yes, Raynaud's is a cardiac issue. So you'll want to talk to your healthcare professional. You might want to get a cardiac specialist involved in it. Raynaud's is, people have Raynaud's who don't have paralysis. It's where their hands get really cold because of circulation is not going well to their hands. And so be sure and talk to your healthcare professional because there are treatments for Raynaud syndrome. And so you want to get involved with them. Some of them are, some people wear gloves to keep their hands warm so they don't get that cold because it keeps the circulation, like some isotoner gloves or, some gloves with elasticity to help that circulation and doing your exercises and doing all those things. So be sure and talk to your healthcare professional about that. Spasticity, how to deal with it when it's in a different part of the body. And spasticity is an interesting thing. And we had a person who wrote in a question about spasticity in that they have neurological injury, but the spasticity is different on different sides of their body. And again, everybody's different, and every injury is different. And it doesn't matter if it's from neurological disease or if it's from a birth trauma or an accident, it doesn't matter. Everybody's injury is different. So, very rarely does speak specifically to spinal cord injury does the spinal cord injury happen that's perfectly even across the spinal cord, that level. When they do the ASIA test, they will give you your level as the last fully functioning level that has normal sensation and movement, typical sensation and movement. You might have on one side, it might be a little different. So you could be like a C3 on this side and a C4 or 5 on that side. So sometimes that's what it is. Now, somebody wrote in and they said, my therapist said that spasticity is a sign that the nerves are working. Okay, this again is one of those good news, bad news stories because, yes, when you have spasticity, that means some message is getting through to cause that nerve to become spastic. Now, sometimes spasticity can become that the muscle below the injury is sending messages up. Where's my message? Why isn't my message here? And so you can get spasticity that way. Spasticity can be seen outside the body. You might have it in your legs, you might see it in your arms, but spasticity can also happen inside the body. So you can get spasticity in your bowel. If you have it on the outside of your body, you probably have it on the inside of your body as well. You can get it in your bladder as well, where your bladder gets out of sync. The bad part about spasticity is it can just be impossible to live with. And so you have to find the balance. If the spasticity has so much taken over your life that it's just controlling everything you do, then you're going to have to take some treatment for spasticity. And we have information about spasticity, which goes through a lot of treatments. Some not medicine, some oral medicine, some with the implants that will help control spasticity. People are getting Botox injections that, they have to be recurring injections, but it helps reduce that spasticity. So there's all kinds of medical treatments and there's all kinds of non-medical treatments that might help with your spasticity. Movement really helps a lot with spasticity, but gentle movement. If you're doing your exercises like this, you're going to increase your spasticity. But if you start just gentle movement, think about people who have arthritis, people who have MS, gentle movement helps calm those nerves and those muscles. So gentle movement. So there's a lot of things you can do. A lot of people who treat their spasticity don't just do one thing. They might take an oral medication, but they might also do some of these non-medical treatments. So spasticity, some people, their foot, gets that kind of chronic spasticity going and it's not bothering them. They're not embarrassed by it. Sometimes they elect not to treat it, and that's fine because that's what's right for them. But when the spasticity starts getting so bad that it's throwing you out of your wheelchair, it's affecting your bladder program, it's affecting your bowels, then it's time to think about or pain. If it's giving you autonomic dysreflexia, it's time to think about some kind of treatment. And again, you need to talk with your healthcare professional. Some people say, well, Nurse Linda, what's the best treatment for this? Well, the best treatment is the treatment that's right for you. So no two treatments are going to be exactly the same, but people are going to, experiment with different treatments. I'll try this medication and see how it goes and I'll try you know, different techniques and see how things are working out. What suppositories are you talking about? Are they laxatives? No, they're suppositories. They work in the lower bowel, and one is called Ducalox suppository, and one is called the Magic Bullet. And those are the two that people traditionally use. There's also this mini enema. It's called enemies that a lot of people elect to do. Now, the enemies company will help you. It's more expensive than the suppository, so sometimes the payer will want you to be on the less expensive program. But if you have reason, medical reason, you can get a letter from your doctor to request something different. Always work on the appeal because a lot of times things don't go through the first request. So keep appealing until you run out of appeals. Just keep going with it. And that is frustrating. It's frustrating for me, it's frustrating for everyone, but that is seemingly the best uh, path to take. Some people get the letter, it says no, it's denied, but look down at the bottom, but you have the right to appeal. You have the right to appeal because sometimes, you know, maybe people don't understand, with the first pass. So always continue with your appeal. Um, let's see, we got a lot of questions coming in today, which is great. Okay, I do exercises 5 days a week with HIT classes and training. Anything else I can do to lose weight? I'm a vegan vegetarian because it works for bowels better than a meat-based diet. For some people, because you're taking all that roughage in the vegetables, and so for some people, it does work better. Other people need the meat-based diet, and I know you can get protein from different sources, but the big vegan vegetarian does not work for everyone. But so they're doing their exercise classes so that, losing weight, you might want to, start counting calories. You might want to talk to your healthcare profession about some of the weight loss drugs. Now, I bring those up and I kind of thinking in my head, do I want to bring that up or do I not want to bring it up? But I'm going to bring it up because it can certainly affect your bowels. Those weight loss drugs work in your brain and they slow your bowel function. So they can make your bowel program a nightmare. So, I very cautiously say that, but there's a lot of different things on the market for weight loss that may help that are not these weight loss drugs that you hear about on TV all the time. And that's one of the biggest problems with those drugs that, they do have side effects, but that is one of the biggest problems is it gives people constipation. And if you have a neurogenic bowel, you really want to avoid that constipation. So it can become very complicated. Um, do leg spasms not count as movement, exercise of the lower body? Well, usually the spasms uh, is really a problem of the nerves and a few muscles, but it's not doing that range of motion. It's not doing my what FDA approved besides the ARC EX. We have a little paper that has all the different companies that are working on these different FES transdermal. And so we're Zach, who's assisting us today. Thank you, Zach. He'll put that up of all the companies because there are quite a few. And so you can follow along with all of them. You can look at their websites. They each have something a little different about them, and you might find one that you like, uh, better, one better than another. So, and look at as magically as it is, I think it's appearing. Oh, stuff about the last question about specificity. So if you have spasticity, it's more like this. It's more like, the small fibers are getting worked out, but it's not range of motion of the joints. And so we want to keep our whole bodies moved, and moving your legs in particular. It's like, remember that song about the bones, the ankle bones connected to the leg bone and the leg, well, your muscles are all connected. So the more you move your legs and your thighs and your hips, the more movement you're going to get as a result in your abdomen, which is your peristalsis. Okay. Um, so the difference between voluntary muscle contractions are one that you are controlling with your brain. You're voluntarily getting that muscle to go. And the ones that you're stimulating with electricity then is um, is giving that input below the level of the injury, or with that tape on the back is going through the spinal cord, but affecting the areas below. Now, the reflexive muscle contractions are just a muscle spasms that's doing it on its own. So it's not under control. It's that muscle is looking for input, that nerve is looking for input, and so it doesn't know what to do, so it contracts. Our normal state of body has a little bit, our muscles have a little more contraction. See, if I hold my hand and I make it completely so that I'm not controlling anything in my hand. You can see my wrist is flexed and my fingers are all flexed just a little bit. Now, with my muscles, I can straighten that out, but our normal state, our body likes to be a little bit flexed. And so if we don't stretch those out and stretch those muscles, we lose the ability to be able to do function. So all these joints and these muscles have to be ranged over time. Can Asia change over time? For C5 incomplete, can Asia move to a B, from a B to a C? At least we hope so. Well, I have to tell you, that is the goal, is to improve. Now, there was a time where we said, nope, you have a spinal cord injury, that's it. We know now, because of much of the work that Christopher Reeve did, we know improvement can happen. We're still refining those techniques to get there, but we know that it can happen. And again, speaking only as Nurse Linda, no scientific evidence, but I expect to see this in my lifetime, especially if you're incomplete, you can often move to another. If you continue with your exercise, continue with your therapy, which doesn't necessarily mean you have to go to a place to have therapy, but do your therapy at home and continue on with that. If you can get your 2 weeks of therapy every year to learn how to up your game and doing your independent therapy at home, be sure and take advantage. Most policies, private payers and Medicaid and Medicare allow 2 weeks of mobility training, and you can go outpatient. Sometimes they give you inpatient. It's different. Every policy is a little bit different. Mostly it's outpatient. It doesn't have to be 2 weeks every day in a row. It could be one day a week until you hit your 2 week threshold. It could be 2 days a week until you hit your 2 week threshold. So always think about that. Mobility training can be almost anything. If I'm learning to feed myself, that's mobility training. If I'm learning to turn myself in the bed, that's mobility training. If I'm learning how to get up on that commode to do my bowel program, that's mobility training. So it can consist of a lot of things. It might be going to try some of these new devices in a therapeutic setting, which then if you have in 2 weeks, you're probably not going to have a significant result that quickly. With some of the products now, you are going to have that significant result. So then you can go back to your payer and you can say, oh, look, I did this for 2 weeks and I got some return of function. I want to continue on with this. And it kind of gives you the evidence. This is working for me. So use these things to your advantage. Uh, Excuse me, I did forget one of the suppository, glycerin suppository, which is in the Fleets mini enema and works well. It's expensive, so they have to buy food grade glycerin, do an anal syringe, which is a way of dealing with some of these prices of things. It stimulates like the Ducalox. For some people, particularly children and people who are older, sometimes the suppositories will become too harsh and they start having incontinence because it's too harsh, or they start having little blood with their bowel movement. So then we recommend the glycerin suppositories, which is a lot more gentle. Younger children, their bowels just work better than, again, as we age, our bowel just slows down over time. And so their bowels are usually more hardy. And so then we'll use the smaller suppository. If they're infants, we'll cut the suppository and force, depending on what you always want to cut it the long ways because you want as much of that suppository to be up against the bowel. You don't want to have it like a loaf of bread. You don't want to do it that way. You want as much boom your suppository. But yes, I did overlook the glycerin suppository, so I um I apologize for that. Um, there's somebody who's talking about menopause here. I don't know if I missed something up above, but we do have a woman's health that talks about perimenopause and, well, it talks about everything in women's health, but there's a chart there about perimenopause, menopause, and the changes in women's bodies. And then it has this is what the change is for everybody. This is what the change is when you have paralysis. It might aggravate something that your body's normally doing. And this is what you can do about it. So it's kind of a nice little chart if anybody is interested in looking at that. Oh, Zach wants to say something. Nope, I guess he changed his mind. Okay. He was maybe talking about that page. Um, With a distended abdomen, is there great likelihood of gut leaking and fecal matter going into the bloodstream? No, not unless the abdomen gets so distended that it ruptures. And I was just dealing with this particular situation, but now it has nothing to do with paralysis. It was another situation altogether. But funny that this should come up because once waste tissue gets into the abdomen, you can become septic and you can die from that. So we don't want any gut leaking. And generally, no, it just distends. The bowel is like a balloon. It just blows, it just keeps getting bigger, bigger, and bigger. Can it get so big that it could actually burst? I suppose so, but I think that is so very rare. I don't think we really actually worry about that too much. Oh, the mobility training was not something we were aware of. Check your policy and make sure it's there. What language should I use when I call Aetna to ask if this is covered? Look at your insurance card, get your policy number, and look up that insurance name and your policy number, and there's a manual that will be online. Now, everybody's supposed to get a policy manual, but I know I've had some health insurance and I never got a manual unless I asked for it. It's better to start out looking it up yourself because what I find happens is sometimes when people call the insurance and they give their story, sometimes they say something that maybe they overshare information. And so sometimes that can affect things. So look up, you can search in these policy manuals and look up mobility training and see what that is. You might have to physical therapy or therapy mobility training or occupational mobility training. Oh, Kelly Kay would like to answer. Go ahead, Kelly Kay. She is our queen of technology.
Oh, I was just putting that so that way you would have it at the top of the list, so that way you would know to answer that one next.
Oh, okay. Okay. Um, Thank you, Kelly. See, she's up on everything. Are all gastrointestinal and gastroenterologists trained in SCI, or should I look for a specialist? It's pretty hard to find people in specialty areas. People go into specialty area like a gastroenterologist, have their specialty in that. Some deal with people who have a spinal cord injury and some do not. It's a matter of how their patient flow goes. So if you can find one who deals with spinal cord injury, so like if you go to your spinal cord doctor, if you have a specialist in spinal cord doctor, or if you're seeing your family doctor, say I'm looking for a gastroenterologist and I want somebody who knows about spinal cord injury, they might know how to refer you. If you're in an academic medical center or if you're somewhere around where there's a large rehabilitation program, you can call them and ask them who they use for their GI specialty, and you can get information that way. If you're in a rural area and you're the only person with a spinal cord injury, you're probably not going to find somebody in that town because there's nobody else but you. So it can be a challenge. You can also call your insurance company and see if there's somebody on their list. Call that number on the back of your card, see if there's somebody on their list that they support through payment, or would they be willing to send you to a GI specialist who's not on their list of providers, but because they don't have one with this mixed specialty education, maybe they would be willing to send you to one. My guess is they will make you go to one that's on their list first. Then if that person says no, you need to see a specialist, then they'll probably refer. That's what I was thinking of. Oh, yeah, Pam, menopause, that causes a weight gain for everybody. And so it's a challenge to keep up with that and to look. You might want to go into some of the advanced therapies, look into some of the advances that you can do even more, and be sure and exercise your lower body because your muscles in your thighs are your biggest muscles in your body, and so you get the most bang for your buck when you exercise your thigh muscles. So that doesn't mean only exercise your thigh muscles, but a lot of times people exercise their upper body and their lower body doesn't work as well. So they think, well, there's nothing I can do there, but you can if have somebody move that lower body for them. Okay, so if somebody's C5, they rely on a Duplex daily. Should I be concerned about the long-term side effects since laxatives are not recommended for daily usage? Is glycerin safer, food grade more natural? No, glycerin's going to be glycerin. It's not going to be glycerin is less harsh, but regular adult people, I shouldn't say regular, typically a glycerin suppository is not strong enough for most adult people. Even in old age, sometimes it's not strong enough. So you don't just want to zoom right off to the glycerin. Dulcolax can be used long term. People don't have trouble with it. I've never seen anybody who's had trouble from some consequence of using their Dulcolax suppository. However, um, I'm sure there's somebody out there that has. So let's see. There's a couple more questions. Here's somebody who has a pressure wound and they've been at this for 4.5 years with this pressure wound. Okay, the longer you have it, the harder it is to clear it up. They go to the wound doctor every 1 to 2 months and they get it dressed and clean once or twice daily. Once you get a wound that is this bad and this chronic, the body has kind of adapted to it now, so it becomes more difficult to clear up. The best thing you can do for any wound is to stay off of it. Now, it's been here this long, so it's not going to be like you can stay off of it for a day or an hour and it's going to heal up. The best prevention for a pressure, the best treatment for a pressure wound is to prevent one. So the minute you see that pigment change on your skin, stay off of it. It might take a day or two for that pigment change to resolve, but that's okay because when you have something like this, it can be trouble. Now there is something that you might this person, since this wound is so chronic, you there is something called a wound vac, which is some it's like a I'm gonna call it plastic. It's not plastic, but like a plastic thing that goes completely over, seals the wound off completely. There's a hose that comes from out of it, and it hooks up to it like a little vacuum, and you turn that on. People complain about it because it's noisy, but if it it's better. It helps exit it out of and that's it. Constantly going. So you might want to ask about that because that seems to be, kind of one of the for these really severe wounds, it really helps. You only have to change it about, it depends on the person, on average about every 3 days, some a little more, some a little less. But it keeps that wound clean and it keeps any bacteria out because it's completely sealed off. So that's something that you might want to ask about. The next thing would be surgery, which gets very involved because, the wound has to be cleaned out, it has to be debrided surgically, and then they have to take muscle and put it over the bony prominence where that wound is, because there's got to be some cushion between that bone that caused the wound and the outside of your skin. There's got to be some tissue in there. And so after those surgeries, though, you might be on bed rest completely off that area for 9 months to a year, which sounds horrific. But if you've been dealing it with for 4.5 years, it might not sound so horrific if you think there could be. The big, huge decision, because it is surgery, and you want to discuss that very carefully with your doctor to see if you're able up to the surgery. If you really want to do this, it's a pretty big surgery, so you want to think about that. Somebody who's having trouble, they're paraplegic, they're diabetic, they switched to a suprapubic catheter, and now they're having constant UTIs. And so they've been taking antibiotics, and it just seems to be a chronic problem. So, and he only spasms when he gets the UTI, which happens to a lot of people because, again, it's something that is obnoxious in the bladder, and something obnoxious will give you spasms or autonomic dysreflexia. At the T5, you could be having that as well. So, this is something to talk about. There's some new antibiotics out. There's some flushes that people are using now. You don't want to just if you have a suprapubic, you don't oh, I want to flush this. You don't want to do that. If you're having problems with UTIs, there's some flushes that they're seeming to have some good luck with. It's probably not necessarily the suprapubic catheter, because the more research, and they're doing a lot of urinary research, and I love that. Talk urine and bowels all day, and skin too. Anyway, um, they're finding that if you have a suprapubic, you're not having that many. In general, people are not having more UTIs than the old way, than what you were doing before. You can also go back. You can have the suprapubic closed if you think that that's the problem. Now, maybe the UTI is implanted in there, and maybe if you go back to intermittent, maybe, it may or may not help. So, um, but you could talk about some of those flushes so that you can see if that will help reduce some of that that's going on with that. Somebody wrote in and they regarding Guillain-Barré. Um, Guillain-Barré is a something that happens and it starts usually at the toes, and it's a paralysis that moves up the body. It goes from the toes to the foot to the heel and slowly works this way. It can go all the way up to the top of the head. Your mind is always present. It does not affect the mind, but it gives you paralysis throughout your body. You can't move your eyes. Sometimes it stops in weird places. Sometimes it stops midway for whatever reason. And then over time, the paralysis recedes back down the body. Now, there is one weird variant of Guillain-Barré where it starts at the top and goes down. We're not going to talk about that so much because it is so rare. So you can move your body, but you might have to use the ventilator because it's going this way and then it goes back up this way. So that's a pretty rare thing. But you will have if it goes up and affects your breathing, you will have a ventilator. If they expect it to be short term, they'll give you one of those external ventilators, which is kind of nice. They became very popular in the COVID, but you can, it's a clean one. It's a new one. You don't have to worry about that, but they use those more. So it's a long-term process for some people. Some people it resolves right away. Some people it completely clears up. Some people are left with a limp or various problems. Some people the disease recedes so long and they might be left paraplegic. So there's a lot of variability, but usually it goes back down and then it resolves. So those are the things. We have a man here who's working on his leg strength, and they want to know, is there hope? Yes, there is hope. So he's working very hard. He's trying to get his leg strength back. He's a healthy core and strong arms, and his right leg's moving. So we're doing a good job here. And again, just keep up with that. Keep moving. Keep up. Keep stimulating the body, and that will help a lot. The pros and cons of pumps. Well, baclofen pump helps with spasticity. They can also put pain medication in it and help with pain. They could put both in it and control pain and spasticity. It's a little implant that goes in the abdomen, and then a tube is run underneath the skin around to the back, and the tube is planted in the spinal column where the spinal cord is, not in the spinal cord. But it allows baclofen and pain medicine to bathe the spinal cord to help reduce some of the problems of the pain and the spasticity. It is a later treatment. You usually try things less invasive first. It is a surgery. Um, it works well for people. There is a technique for putting that tube in so that it doesn't become dislodged, and there's special techniques. So you want to be sure that they know how to tie that tube in. But people who put them in, they'll know that because otherwise it can slip out. They do have to be refilled. Is there anything that is any cons to it? Well, there's cons to everything. Mostly they're put in the lower back and work on the lower body, but sometimes they're put higher up. The baclofen is of a heavier molecular weight than your spinal fluid, so it tends to stay in the lower spinal column. If you get one higher up and it's being delivered up higher in the upper back area, sometimes that can travel up and can affect your breathing. But if it's in the lower back, it doesn't. So those are some things that I know about that. You always have the risk of infection and all those kinds of things, but they're pretty safe and pretty convenient to use. Um, let's see. Um, oh, spotty audio again. I'm sorry about that. Hydrochlorothiazide, 25 milligrams, 1 a.m., 1 p.m. works at hydrating laxative, originally supplied for high blood pressure. So interesting because hydrochlorothiazide rids water from your body. So that would also work in the bowel, which would put more water into the bowel. So if you happen to be taking that for high blood pressure, thank you, Peter. we get an unintended side effect of making the stool more moist. So that's quite a nice little tip to hear. I like hearing that. Can bruised spots, toes be a cold injury, circulating, possible pressure sore, discoloration lasts 6 to 8 weeks, and skin flaked off like a healed blister? It sounds like a bruise. So, oh, and call it a bruise. So it sounds like a bruise, maybe from an injury. So, um, could it be from cold? If you go out in the wintertime and you don't have your feet protected and you don't have sensation, you can get frostbite. So it could be something like that. But that can be really dangerous because if it was, you can lose that toe, or you can you could lose your whole foot from that frostbite. So it could have been a frostbite injury that you caught early enough and got inside soon enough, or it could be if it was right on the kind of the knuckle of your toe, it could have been a pressure injury, which could heal like that. They usually heal from the top. Pressure injuries usually heal from the top of the skin into your body. And that's why we keep them open. So we want it to heal from the inside out. It sounds like it healed from the inside out. So it sounds more like a blister to me. But, that we have to see. Well, now we're coming to the end. And so I did want to just say one more thing, but somebody wrote in, and I wanted to leave time specifically for this question. And this person writes in, my SCI is never going to get better. And I'm enjoying this, Linda. But I do want to tell you, right now in the time we're in, and I alluded to it earlier, spinal cord injury is going to get better and people are going to get more function. It may not be exactly like you had it before, but we're having these treatments that are coming to fruition right now. These are not things that are in the pipeline. These are treatments that are coming to market, and lots of these treatments, and a lot of them are going to help bowel and bladder. And as these treatments will continue to improve, when we first started out, we were doing FES on the bike, which is great. Great for exercise. It has a lot of great side effects, which are good side effects. So that was really a good thing. And then people said, well, what if we put that in their spine and gave them more function? Well, that worked out really well. Not perfect, but that was high risk because you're doing surgery in the spine. Wow, that's pretty dangerous. And then now they've got this tape on the back. So look at how far we have come. And now things are just exploding in all healthcare research. So we're having more and more with learning about the chemicals in the body and how they can be affected and improved. Genetic engineering. There's just so many things that are going on right now, and they're all coming to fruition right now. So with that, I've overtalked my time. I'm sorry about the problems with the connections. I don't know what was going on there. But anyway, we'll investigate that and see what happened there. But thank you for coming today. And remember, Christopher Reeve, forward. That was his motto. We always have hope for the future. And we have a lot of hope right now. So keep that in mind. And I'll see you next month.